very interesting topics. So now I open the discussion panel, so people can submit questions either through Q&A or people in the audience can ask questions. Make sure press the button, microphone button, so everybody can hear us. Also, we can record it. How do we get this question from here now? Okay, let's just go over that submitted question here first. So the first question is, so what is the instance if a secondary malignancy is in patients who receive high dose rate boost? This must be for Dr. Ink.
Well, I have to admit, I don't think I know that data off the top of my head. Dr. Bain, are you familiar with any of that?
So I don't know of any solid data. I know that theoretically it should be less than what we would get if we got external beam to a full definitive dose, just because you have a faster dose fall off. But I don't know of any solid data that actually shows that. But our secondary malignancy data is murky in the first place.
I would agree with that, and I'm not aware of any data that's compared secondary cancers and LDR, HDR, but since somebody brought the question, I'll do a lit review and see if I can find anything.
Well, along that line, actually, I do have a question for Dr. Ing as well. So, what would be the toxicity or complications with external beam plus boost, brachytherapy boost?
So in the ASCEND trial, where patients were getting a reasonable dose of external beam, and that was in conventional. So everybody got 46 gray to the prostate and pelvic nodes. And then the group that went to what was considered standard had a cone down boost, and that went to 78 gray with conventional fractionation versus a LDR brachytherapy boost. And one of, in a separate publication on the ASCEND trial, they looked at issues regarding kind of quality of life, and particularly GI and GU morbidity. And grade 3 GU toxicity for the LDR boost group was 18% grade 3. And it was increased for a grade 3 GI, but not over compared to conventional fractionation, but not enough to be statistically significant. That being said, I think it was about double. And that was one of the comments that I made, having been somebody who's done both. I have infinitely more confidence in my dosimetry and my ability to control my urethral dose, as well as a rectal dose doing single fraction HDR in the OR setting than I do when I was doing low dose rate seed implants.
Okay. Well, before we move on to next question, this is regarding radiomics. I do have a couple of questions for Dr. Boyle. One is that now we're doing the image fusion, ultrasound, MRI scan. How about functional scan, like a PET scan?
Yeah, so I haven't seen anybody using the PET scans yet in prostate cancer, and I think there's a number of reasons that were touched on in some of the imaging talk done by our colleague here, who's a senior resident. And I think that the PET technology with prostate cancer is still moving along in its ability to detect things, and so we haven't really looked much at using it in the setting primarily. I do, however, see a number of patients who come to me with an incidental PET scan finding, and those patients I usually get an MRI and a fusion biopsy.
So then the next question for Dr. Boyle as well is for patients who had definitive radiation therapy, and with resting PSA, you suspect there could be local recurrence. Would that fusion biopsy help you to identify the recurrent disease?
Yeah, so Dr. Ink and I share a patient who had and ablative technology used on a high-risk prostate cancer. And in the setting that his PSA was increasing, we did use fusion biopsy to confirm a recurrence. And I've also used it, we can track where the biopsies are taken from and save that information. And so when I have patients who have Gleason 3+4 who refuse treatment and I'm following them, I actually will ask the radiologist to target the same area I biopsied. I'll say to them, can you put a target on biopsy number X? And they'll do that for us. And I think that that's really one of the incredibly good instruments that we have with fusion biopsy.
And I was going to say, you know, as we look at doing salvage brachytherapy, I wouldn't begin to consider offering that to a patient without pathologic confirmation. I wouldn't rely at this point on imaging alone.
So from audience, anybody has any questions for Dr. Eng, Dr. Boyle? Okay, let's move on to next question. Oh yeah, Andrew, yeah, Dr. Wall.
This question is for Dr. Anker or Dr. Bain. Do you have any dose constraints for your pelvic external beam radiation therapy when you combine it with brachytherapy?
So that's a really good question, and the answer is that we don't have any real black and white dose constraints for what to do with the pelvis after we do HDR. What I have done is I have basically had my dosimetrists run the plan as if everything was going to be external beam, just to make sure that I'm going to meet constraints for rectum and bladder, because I know my dose with HDR is going to be at least as good, if not better than that. And then end up, as long as that meets constraints, then I just end up treating the pelvis portion of that.
You know, and I think I do something similar now when Dr. Bain and I are doing an HDR case. We have very rigorous sets of dose constraints for the urethra, the bladder, and the rectum, both kind of primary goals as well as multiple secondary goals that we try to target. And the other thing that, to your point for asking the question, since I don't think there is great data on this, one of the things that I think we employ frequently is hydrogel spacer. And the way we do it now, we put it in after the HDR boost, which is really our first line of treatment. And that also certainly gives us a lot more confidence that we'll minimize rectal toxicity, although certainly the hydrogel spacer doesn't do anything to minimize GU toxicity.
Okay, let's move on. Next question, submitted question, has to do with the cost. So has there been any discussion regarding the use of radiomics on financial impact on cancer care? It must be submitted from insurance company. Anybody want, well, no, Mike or Dr. Then you may want to answer this question. It's a difficult question to answer. So. But that applies to everything, right? Not only just radiomics, every new modality, new treatment. So.
Dan, and chime in as you see fit, but basically, I have not seen any actual analysis done looking at how this will end up impacting healthcare costs, and I think there's multiple reasons for that. The first is that radiomics is still very preliminary, at least in my mind, and so we don't really even know what it's going to look like as far as how it can be implemented. And so it's hard to actually judge healthcare costs and how they may be impacted based on right now what is still a black box mechanism and something very preliminary. Second, you know, the reality is one of the promises of radiomics is the fact that you're already using imaging by and large that's already being done for these patients anyways. We're not getting new imaging tests, we're just doing a different analysis on imaging we already have. And so once we actually have a radiomic signature that we know what to do with and how to interpret, it should be a very minimal added cost to the actual analysis of our normal imaging. And so it should be negligible.
Yeah, I agree with what Mike just said. I think this, again, I did not look at the literature and also I'm not aware of the literature that's analyzing this. But I think for the kind of, as all the talks pointed out in this session, it's really important to differentiate patients into different risk groups and give them the care that they needed. So if we can substantiate the power of radiomics in detection and diagnosis and better prognostication, then there's no doubt that this would save a lot of dollars by better putting these patients to the risk groups to receive the best care. And as Mike said, because these kind of applications are really still in the early research stage. So I guess the eventual financial impact will be unfolded as these move on to deployment. And another aspect of this is basically the worry or possibility of replacing certain workforce with these AI tools. And this probably we have seen more discussion since in our field, and also I think because in radiology particularly, a lot of these AI tools have been clinically implemented. And what I see right now is that people tend to adopt it in the way that it's still the radiologists are utilizing the same AI tool to augment what they regularly do, and that improved both the performance and also the efficiency of how they do things. But again, I think that's also an open question, how as the field evolves, how it will change the whole field. But I think just kind of like many radiologists nowadays believe that, they don't believe that AI tools will replace radiologists, but they will replace the radiologists that don't do AI.
Okay, thank you. So I agree with you. I think this is all still currently under research, and I have no doubt, and all research on cancer care will lead to more effective treatment, but also probably more cost effective as well. And a couple of technical questions. So that's just my question. I will look at one of the slides, then present it. So I was puzzled by the fact that just the simple convexity of the pulmonary nodule, like I assume that lung cancer would have a survival benefit. So that's probably just just one factor. I'm sure there are many factors that would affect prognosis. So my question is, how would you make sure, you mentioned, we don't put it in garbage, because garbage in, garbage out. So that's just in my observation and my questions.
I think that's a very good question and very important consideration, because these features, and as it moves on to kind of deep learning space, it's less and less interpretable directly and makes less and less intuitive sense to us humans. But it's really important to try to perform extensive and independent validation, and also on the other end to improve our methodology to try to improve the interpretability of these AI methods, and also to analyze the causal effect of the basically medical imaging appearance and the underlying biological effects.
Any questions from the audience? Okay, Kevin.
All right, because I have a few. I think I'd like to ask Dr. Zhang, Dr. Zhang, a question for the future of radiomics. I think one question I'm always confused is, those parameters are difficult for human brain to interpret. But who came up with all those 500-700 parameters? And is there any potential to come out with 2,000, 3,000 more parameters that makes the future even more potentially diagnostic?
Yeah, so actually, I think currently the number of features are actually already in the thousands or even tens of thousands domain, because the initial or original features, there are about in the order of hundreds. But then when you apply different image processing filters onto the original images, then these derived features can then multiply fairly quickly. And in image processing, we already have many different filters that we can use to try to emphasize the edge or smooth the image or whatever the purpose of that. So the number of features is actually not directly indicative of the search space. And also the current deep learning methods, they kind of moved away from the segmented ROI and handcrafted features and directly use these deep neural networks to try to come up with its own features on these medical images to try to fit whatever applications that they are trying to predict.
The second question is, I keep hearing the area under the curve being like 0.8, 0.9. From physician point of view, I guess once you get that accuracy close to biopsy, to gold standard, it clinically is supposed to be possible replacing the gold standard. But I guess from your point of view, from Dr. Bain, when do you think you can get to that step? Either magic them.
I think this really, I don't think there should be a single answer to this question, because for different applications, the performance number will look quite different. Just for example, for the simple or lung cases, the AUC can be quite high as, but for something like pancreatic cancer, the number could be much lower, but still be an improvement of the current clinical practice. So
that's my question too, because radiomics has almost infinite potential, right? With all the filters, algorithm, human, let's say biopsy, that we have limited technique. Even with like our Dr. Boyle become much more skilled with years of more practice. I guess we can only reach to a certain point.
Yeah, I'm sure we'll have more questions and answers for sure. That's a very broad topics. So I have a last question. A couple of minutes left, so I want to move the last question. In patients with avid lymph node outside the standard nodal field, did any receive the ADT, or did the ability to cover the avid lymph node adjust decisions related to the ADT or other systemic therapies?
I think we commonly use ADT in this setting, and in all our patients that are getting radiation therapy in the salvage setting. And I'm not sure that we've said, oh, if I can't treat this lymph node with radiation, I'm going to change my ADT recommendations. I think that we are giving those ADT recommendations regardless of our ability to cover those lymph nodes. I don't know if Mike or
Dr. Anker, you want to address that?
Yeah, I mean, I think from my standpoint, so for example, if I had a patient with a common iliac borderline low parodic lymph node, more than likely today I would extend my nodal field to include a good portion of the parodic node and at least treat that volume to 45 gray or 46 gray, and dose paint the node as I described before up to 75 gray. But I think the other thing conceptually that I think about is that this is a patient with advanced prostate cancer, and therefore I would probably extend and would not use, for example, short course or 6 months of ADT. I would take that really for at least a full 28 months. Now, sometimes you run into this with older patients, and then, I kind of say, well, let's at least try to get to 18 months and see how they're tolerating it. And if they're tolerating it okay, make the play to go longer. But I think that's the group that probably likely benefit from the longer course of ADT.
Okay, well, I guess we're out of time. I'm sure we may have more questions. And you can always approach to the speakers later. So with that, I'd like to conclude the morning session. And I think afternoon, we'll have also excellent presentations, talks. We'll begin at 1:20. So we'll have an hour lunchtime. Thanks again for everybody. We have food, right? I think we're having lunch. Yeah.
So thank you so much. Can we put a break on?
Yeah, this is.
There's a break.